Good evening, everyone. I'm delighted tonight to welcome back again Dr. Suzanne O Sullivan, who is a long-time colleague of mine. Suzanne is a gynecologist in Cork, is a consultant gynecologist at the University Cork Hospital, but she's also a specialist in urogynecology, which is the branch of gynecology that really looks after all bladder problem, including urinary incontinence. So thanks, Suzanne. Thanks for talking to us again tonight. The reason why I asked Suzanne to join us is because I'm a little bit concerned about all the advertisement I've seen recently in the media on urinary incontinence treatment. And there is a lot of advertisement of new treatments available that I'm not so sure it's really done in the right way, in the right place. So I'm going to start, Suzanne, to asking you about the two types of incontinence again. Tell us again what they are and why it's so important to know which one you have.
So good to see you again, Rita, and lovely to be back. Thank you. So the most important thing is that incontinence is absolutely unpleasant, devastating for women. It's great that there's a lot of talk about it and there's the conversations is out there in the media and in social media. But there are some things that we need to really keep in mind. There are two main types of incontinence in women. The first is stress urinary incontinence. It tends to be younger women with stress urinary incontinence, and this is when they leak purely, very briefly, with associated with exertion only. So an exercise, a cough, a sneeze, sometimes a laugh, uh, running, jogging, going on the trampoline. So an exertion happens and a squirt of urine or a leakage happens, and it is not associated with any urge. The other kind of incontinence, which is sometimes called urge urinary incontinence or overactive bladder, is where women tend to need to go quite frequently. They have difficulty holding on, and they can be sitting there watching television or doing an activity. They get a sudden urge and the urine comes away, or they have an accident or leak before they make it to the toilet on time. Now, rarely this kind of urge incontinence can be associated with exertion and can appear or masquerade like stress incontinence, and that's when things can get a little bit confusing. The other thing is that probably 30 to 40% of the women who attend our clinics have a mixture of both. They have an element of both kinds of incontinence. And as far as the woman coming in is concerned, she only cares about the leakage that she gets, the inconvenience in her life, the embarrassment, the changing of her clothes, etc. The reason it's so important is that the treatments for stress incontinence and urge incontinence are entirely different. So, treatment for stress incontinence will not help somebody with predominantly urge incontinence, and the treatment for predominantly overactive bladder or urge incontinence is medication, and it will not help somebody with stress incontinence at all either. So, the most important thing, as far as I'm concerned, is going and getting help from an expert physiotherapist or from your GP or from a gynecologist or urogynecologist. The most important thing is taking a good history and trying to elicit what is the most likely main diagnosis, whether it's predominantly or purely stress incontinence or predominantly or purely overactive bladder or urge incontinence. And if it's a mixture, which is the main problem to be addressed first, because the treatments are so completely different. Um, I suppose, again, the reason that seeing somebody who is expert in the field is so important is that they will do a vaginal examination and a pelvic examination, and that will allow other causes for urinary incontinence. For example, bad prolapse, a uterine fibroid, worryingly a pelvic mass, or another issue that may be related to the incontinence, to be looked for and ruled out, because some women who come with incontinence have it because they may have a large pelvic mass, or there could be something else that's worrying going on. And then we can safely proceed with treating the urinary incontinence and knowing that we're not missing something else.
Thanks. That's very clear, and that's really important. I've recently seen a patient who came with urinary incontinence looking for treatment, and she actually had a tumor. So these are things that if you don't get examined are not going to be picked up. Um, One of the reasons why I'm concerned is because this treatment, as I said, are advertising in cosmetic clinics, in clinics where no examination takes place. And that's the reason why I asked your opinion about it. So what's your opinion on this particular treatment? There's one in particular that I wanted to ask you about, which was the Mcella chair, which is seem to be everywhere at the moment, and none of these places seems to offer a medical assessment or a medical exam.
Yes, and as I say, it's great that the conversation is out there, and I've certainly heard some of the ads on the radio and on social media. Um, Again, the importance of a history and examination by somebody who knows what they're doing is just cannot be overestimated. I can see it from the woman's perspective. If I've got incontinence and I'm really busy and I've got kids and I'm running around, the option of a walk in, walk out, painless, sit on a chair treatment, no examination, book your slot on time, walk in, walk out. I
Without
can see
taking
the
your clothes off, because that's what's advertised. You don't get undressed at all. That's really attractive for some women. Yeah.
I think that would be attractive for me as well. That sounds perfect. However, you need to know that it's the right thing for you. So the way the Emsella chair works is that you sit in, and the chair, the outside the pelvis, causes your pelvic floor muscles to contract really rapidly in a short period of time. So you get really high levels of contraction, which is great for building up the pelvic floor muscles or for any muscles. So that can certainly help improve muscle tone, muscle contraction, and muscle bulk. The thing about stress incontinence, and this is where the Emsella chair is being advertised for, is that stress incontinence is caused by a laxity or weakness of what's called the pubourethral ligament, not a muscle. So it's a ligamentous problem. Now, physiotherapy and pelvic floor rehabilitation can compensate for that by improving muscle tone and building up pelvic floor muscles. And that's how physiotherapy works. However, if you have a really good pelvic floor with no problem in the muscles and your muscle tone and muscle contraction are completely normal, then putting it into overdrive is unlikely to fix your urinary incontinence. If you have a pelvic floor, which is not uncommon, that's already in a slightly hypertonic or sort of hypertonic situation where the muscles are in a little bit of spasm all the time, which you will only know by examining and feeling for tenderness and feeling for muscle bulk. And as I say, that will be by a physiotherapist, GP, or gynecologist. Then you could potentially, well, certainly it's not going to help your problem. The women where an Emsella chair can be really useful are women whose pelvic floor muscles are not contracting. And when that happens, it's usually as a result of childbirth. The baby's head crowns, the nerves to those muscles get pulled off, and the brain therefore cannot connect with the pelvic floor. So I would examine somebody, do a vaginal examination, ask them to squeeze my finger during the examination, and if nothing is happening, well, they need expert physiotherapy. Now, traditionally, the kind of treatment used for that is called electrical stimulation, which is essentially like a slender tone into the vagina under the supervision of a specialist physio. And those muscles are allowed to contract from the electrical stimulator, and that starts them working again because usually they've thinned out and atrophied a lot, and B helps regenerate nerve ingrowth to those muscles, trying to allow the brain to connect again. So the Emsella will be a very magnified or multiplied version of that, and certainly can help those women. What we don't know is how long it's going to work for, and it's a 6 courses, I think, over, I can't remember how many weeks, but that effect will build up and will happen. But how long will it stay for? And again, if you're not with a physio who can then measure how you're maintaining that contraction, and if the brain is connecting back up again, then you're really not going to know whether it's going to work in the short or medium term.
And I suppose that's very important, because it reminds me of the slender tone that was so popular in the 80s. You remember that thing that used to supposed to give you a six pack, but when you stop using it, the six pack goes. So I mean, what's going to happen to your vaginal muscle? I presume the same thing if you don't keep using them. So if you haven't learned to use the muscle yourself, which is what the physiotherapy will teach you, and you're doing it passively with an external force, it's just not the same thing, isn't it?
No, and it's not something that you are likely to be able to keep doing regularly for the rest of your life.
Yeah. And I suppose the other thing that worries me, and that's what I wanted to ask you about, is okay, you might not get any benefit for it, or you might get short benefit, but you spent your money, it's not the end of the world. That's not a terrible thing to happen, maybe. but what can anything go wrong? Which is really what worries me. There are things that can go wrong with that if you're doing it for the wrong reason to the wrong patient.
So I suppose, look, it is a safe treatment on the whole. It's causing, multiple quick muscle contractions, which is not dangerous in itself. However, if you've got a patient or a woman who already has what we call hypertonic pelvic floor muscles, which is spasm, if you like, and it's quite common. When it's there for a very long time and it's quite severe, it can cause chronic pelvic pain. It can certainly be related to overactive bladder symptoms. It's very associated with pain with intercourse because these muscles are very tight and they're very tender. If you have somebody who's got a tendency to that or who already has that, or even somebody who's completely normal, you can drive them into quite severe pelvic floor muscle hypertonicity, and you can cause pelvic pain to occur. And sometimes this problem can be really quite difficult to treat. So the physiotherapist has to get into the vagina and release these muscles, which is not comfortable for the patient. It's quite difficult techniques from a physio perspective, and it can take quite a long time to get on top of. And rarely we have to actually use Botox to relax those pelvic floor muscles in patients who've got very severe spasm and hypertonicity. So again, if you don't know that you have this problem, you could get it as a result of this treatment. And it goes back to the original message. See somebody who knows what they're talking about. A good physio will be able to do a basic exam, a vaginal exam, and say, yeah, your muscles are not moving at all, or they're in overdrive, and we need to release them before doing anything else, and get the right advice for your problem. Simple as that.
And Suzanne, you mentioned that, and I just want to ask you again. So let's say that you have incontinence because you have an overactive bladder, and you go in a hypertone of the muscle, then you're actually making it worse. Is that correct? So can a hypertone of the pelvic floor cause incontinence as well?
It certainly can be associated with it, because the nerves to the bladder, it can cause clitoral pain and vulvar pain as well.
You don't
These
want
nerves can
clitoral
travel.
pain. That's not a good thing to have.
Well, they travel through these layers of muscles and ligament, and again, if things are very tight, it can cause it. Can be associated with irritability of these nerves. Yes.
Okay, Suzanne, listen, thanks very much. Take home message. What should patients do?
There is such good advice and expertise out there. See a physiotherapist, a women's health chartered physiotherapist. They're all over the country. They are your best friend, the most important thing. Also see your GP. But if you think that it's mostly stress incontinence, which is typically leakage with exercise, jogging, etc., then see a physiotherapist plus or minus your GP, and go in the right direction. If you think you've got both, see your GP and a physiotherapist. If you're mostly urinary incontinence and it's not related to exertion, again, that's typically more common in postmenopausal women, but not always. See your GP or reach out to gynecology services, urology services. There are specialists in this field all over the country. There's really no lack of care, but get the right advice, and that will save you time, energy, money, everything else, and get you back to normal as fast as possible.
That's great, Suzanne. Listen, thanks very much. That was very clear as usual. Your advice is always so spot on. Thanks again for that. And if I have any questions from patient, I will pass them on to you.
My pleasure, Rita. Thanks, Mel. I'll see you again soon.